Okay, thank you for joining us today, everyone, for the final Davis lecture of the 2022 spring quarter. Thank you for your patience while we rescheduled today's webinar, and we're really excited you all could join us today. Please keep checking periodically the CHAS website or sign up for our monthly e-news to stay updated on the upcoming Autumn 22 lecture series lineup. In a moment, today's moderator, CHAS co-director, crime lab director, and professor at the Crown Family School of Social Work, Policy, and Practice, Harold Pollack, will offer brief opening remarks and introductions of Matt Epperson, an associate professor at the University of Chicago's Crown Family School of Social Work, Policy, and Practice, and Sam Guz, PhD candidate in the Crown Family School of Social Work, Policy, and Practice. If you have any questions during the presentation, please type your questions into the Zoom Q&A pane or the chat function. The moderator and the panelists will address questions following the presentation as best they can. And a recording of this webinar will be available on the CHAS website, which is chas.uchicago.edu, as well as on our CHAS YouTube channel, which can be found by searching YouTube for the Center for Health Administration Studies. And now Harold Pollack will introduce today's presenters.
Thanks so much, Keith. I'll be very brief in the introduction because both Matt and Samantha have assured me that their moms are not on the Zoom. So I'll just say it's an incredible pleasure today to have both Samantha and Matt on this. They bring the real craft of social work and criminal legal system policy analysis to this work in a really impressive way. Of course, just about everybody on this Zoom is probably familiar with Matt's work here at Crown. Matt's been as a long-term faculty member, and if you haven't seen it, Matt has a lovely essay in the New York Times that I'll put in the chat during this that gives a sense of his own tactile experience helping people who have criminal legal system involvement, and Samantha also has is a doctoral student at Crown and also an LCSW, and has real serious practice experience that's just been critical in this work. And I do a lot of work at the health lab, and Matt and I have collaborated on some work, and I hope Samantha and I someday will collaborate as well. But one of the things that really strikes me is that when we publish a paper, everybody wants to talk about table 2 in the results section. And you get lots of nachas for the regression table that you had, and that's like 10% of the work. The real craft of this is relationships. It's being in the environment. It's knowing how to help people and how to talk to people, and to bring the research alive by being attentive to its human and organizational realities. And I think that a lot of what you'll learn today implicitly is the way that Matt and Samantha have really done that in this project, but I just think is really terrific and deals with just the critical issue of mental health and behavioral health challenges among individuals with criminal legal system involvement. So with that, I'm going to pass it off to you guys, and I really look forward to the conversation. Thanks.
Great, thank you, Harold. Really appreciate everyone attending or watching it on the recording. Again, I'm Matt Epperson, and really excited to present some initial findings from an ongoing implementation study that aims to conduct behavioral health screening and care coordination in the Cook County adult probation system. We'll dig into that much more in a few minutes. I'm also really pleased to be presenting with Crown doctoral student Sam Guz, who has worked as a research associate on this project and has really been integral in the implementation. I think part of what you'll hear, as Harold alluded to, is that this is very much a real world implementation project, and as any real world project does, it has its own challenges and constant sort of moving targets. And so Sam's practice experience as a social worker in multiple systems and developing knowledge as a researcher has really been integral. So our agenda, we're going to start by framing some of the issues and previous work that led to this study, which focuses on issues of behavioral health and criminal legal involvement. we're going to focus most of the presentation on the implementation of the Catamage tool, which you'll learn more about. And to guide that presentation, we're going to be using the interactive systems framework for dissemination and implementation. So you hopefully will learn a little bit about that and how that helps to frame our looking and working through implementation processes. We'll also discuss significant challenges faced through the COVID-19 pandemic, which hit this project about midstream and caused, as I'm sure many can relate, it disrupt all aspects of our lives, and this study was no exception. And so we'll talk about that because it was really a key sort of turning point in this project. And then we'll present some very preliminary results from the pilot implementation, from some of the screening results, and focusing on how the project is moving forward. And we'll be sure to leave plenty of time for Q&A and discussion at the end. And as Keith said, you can, if you would like to, you can submit, questions ahead of time, and we'll dig in on those during the Q&A. And Sam and I will be going back and forth, so I'll hand it off to you, Sam.
Thank you, Matt. So before we dive into implementation and talk about the project, I want to first frame the problem and motivate an implementation project focused on individuals sentenced to probation living with serious mental illness. And so I'd like to draw everyone's attention to the right of the screen, which is this pie chart from Prison Policy Initiative. This data was released in 2022. And the top of the pie chart, it reads, incarceration is just one piece of the much larger system of correctional control. And then within the pie chart is the number of people sentenced to probation in the United States at 2.9 million. And so this really indicates and illustrates that while people think about mass incarceration, they often go to thinking about people who are incarcerated in prisons and jails, that actually departments of correctional control are a large part of the criminal legal system. And that research indicates that over 500,000 people living with serious mental illness are on probation in the United States, and that clients living with serious mental illness sentenced to probation are more likely to experience probation violations and be terminated unsuccessfully, which has rippling repercussions for their involvement in the criminal legal system, as well as their holistic health outcomes moving forward. And then more conceptually, the expansion of mass incarceration in the criminal legal system, particularly the ballooning of probation departments and other correctional departments, has not been met with an expansion of services for people living with serious mental illness. And so I want to contextualize this problem to Cook County. In Cook County, over 18,000 people are sentenced to probation. And right now, there's no process in adult probation in Cook County to identify people living with serious mental illness in the system. And then there's no clear pathway to connect people to community-based services who are in the system, and doing that in a way that's voluntary and not mandated. And so when we talk about identifying people living with serious mental illness in the probation system and then connecting them with community-based services, screening, system-wide screening, is an essential part of that process. And so engaging with the project, doing system-wide screening around mental health and substance use, there are ethical questions that are raised. Smart Decarceration Project, a lot of the work we do focuses on decreasing the shadow of the criminal legal system. And so for us, we're constantly grappling with questions about how we pursue this work without expanding the criminal legal system. So how do we make a connection to, for people living with serious mental illness to community-based services in a way that is not coercive, that is voluntary, and that is not mandated by the criminal legal system? And then if we are doing system-wide screening, asking people about their experiences with mental health and with substance use, how do we protect people's privacy? Where does that information go? Who has access to it? What do we do with it? And then more broadly thinking about, as we write and talk about this project, how do we prevent the further criminalization of people living with mental illness in society?
So before we get into the current study, I think it's important to take a little bit of a step back and talk to you about some of the previous projects that really informed this current study. So first, just briefly, it was probably over 10 years ago, I did a study started a study with the Cook County Adult Probation Department, which is one of the largest probation departments in the country, with upwards of 10,000 people entering that probation system each year. So on any given day, they have, between 15 and 18,000 people on probation. I was interested in that initial study about how the various probation programs address issues of serious mental illness and more broadly behavioral health, including substance use issues. And through that work, it really helped me to learn about this complex system and the lack of screening for behavioral health issues. So although they had some specialized programs focusing on drug issues, substance use, as well as mental health, there wasn't a standardized, consistent way to identify folks that might have those needs that would best be served by those programs. A few years later, there was an effort led by the Cook County Office of the Chief Judge and Cook County Health. They received funding from the Department of Justice through the Bureau of Justice Assistance through a mechanism that some of you might be familiar with called the Justice and Mental Health Collaborative. And so this effort was a 2-year project that involved cross-system collaboration and planning. Over 30 agencies were involved, including many actors in the criminal legal system, folks from the mental health and substance abuse treatment agencies across Cook County, people with lived experiences of having sought behavioral health treatment and or being involved in the criminal legal system, as well as advocates and researchers. So I and some doctoral students worked as the research partner on this effort. And the goal of that collaborative, the JMHC, was to do collaborative planning to identify strategies to reduce the prevalence of people with serious mental illness in the Cook County Jail. And so some of the activities that we went through over those 2 years of meeting were just regularly meeting back in what felt like a very different time, where we had in-person meetings with usually upwards of 40 people from these various agencies, where we really thought through many of the issues. Early on in the JMHC process, we had a 2-day workshop that was facilitated by experts in the sequential intercept model. If you're not familiar with that model, it's essentially looks across the criminal legal system at 5 intercept points, as well as an intercept preceding criminal legal involvement. So everything from interactions with police all the way through the courts, and potentially looking at incarceration settings and post-release. And this 2-day workshop really engaged with the various agencies involved to identify needs and opportunities at each of these intercepts. The JMHC also, was fairly complex work, and so there were subcommittees created, including ones focusing on diversion, how to enhance community supports, and then issues around data and policy. So I know it might be difficult to read all this, but this is a logic model, which is really a key part of the research practice partnerships that I work in. And Sam and I, are actually working on a paper, finishing a paper talking about the use of logic models to facilitate community engaged research. So because this was a planning effort, the JMHC, we really focused on how bringing together these disparate stakeholders working across systems was essential for addressing real world multi-system problems. So I put a circle around one of the outcomes, which is that this process, really focused on across the criminal legal system. It's key to effectively identify people with behavioral health needs. If we are really going to try to reach the goal of reducing the prevalence of people with serious mental illnesses and other behavioral health issues in the criminal legal system, identifying folks with those needs across the system is critical. So one of the goals that came out of this project was that we really needed to work on selecting a screening tool. And so many screening tools that look at a variety of mental health and substance use issues were reviewed and discussed. Again, this was really lively discussion because we had folks both who have been clients in these systems and folks who deliver these services, as well as folks in the criminal legal system who could talk about how feasible those instruments could be in their settings. Simultaneous to that, Cook County Health had started to do work with Robert Gibbons, who is at the University of Chicago and who is the developer of this Catamage tool, which you'll hear a little bit more about in a few minutes. But they had started a pilot of the Catamage tool in the bond court. So sort of early on in the criminal legal system, when folks soon after they're arrested and go in a bond hearing. And because that work was relevant to the priorities of the JMHC, Robert and other folks from Cook County Health came to the JMHC and gave presentations on this initial implementation. Ultimately, the JMHC helped to facilitate collaboration and a willingness to pursue tangible, innovative programs, which led to two interrelated projects that I'll focus on today. So these are really projects that are interrelated. I'll give a really brief overview. So the first, which is going to be the focus of this presentation, is a project based that I'm the PI on and Sam's working closely on through the University of Chicago, which is really focused on supporting and studying the implementation of a behavioral health screening tool in a large probation department in Cook County. Looking at how feasible the implementation could be, what are the key implementation issues, and ultimately asking the question, is a sort of system-wide screening feasible? Is it actually possible in a large complex system like this? And also looking at what data could be analyzed, both from the screening tool, the Catamage, alongside other kinds of probation data to better understand how people living with behavioral health issues experience probation and what kinds of analyses could be done to inform probation practices and behavioral health services. Simultaneous to that, Cook County Health had received funding from the Department of Justice, which was sort of a next step after this JMHC meetings, to identify people specifically with opiate use disorders in the probation setting and to provide service linkage. So these two projects really dovetailed nicely, because for the project that I was leading, if we were able to implement a screening tool within the probation setting that addressed both mental health and substance abuse issues, then that could better facilitate Cook County's Health's identification of people in the probation system that had needs, with a particular priority on opiate use, but they also looked at a variety of behavioral health needs and how those folks could be more efficiently connected to services. So as I said, today's presentation will focus mostly on the Catamage implementation itself, but we would be happy during the Q&A to discuss issues related to the service delivery piece that has been led by Cook County Health.
So now I'm going to talk about the Catamage. So the Catamage stands for Computer Adaptive Testing Mental Health. It's a validated tool used to identify mental health and substance use needs. And it's a non-static screening, which essentially means it's a bank of 1,500 questions. And the way a person answers previous questions dictates what questions come next. So there's not a set time for how long a person might spend taking the Catamage and an exact order of questions. The Catamage is available in English, Spanish, and Chinese. Our project used the Catamage's ability to be in English and in Spanish. It can be accessed remotely on a number of different devices, including desktop computers, tablets, and smartphones. And then there's this option to have the questions and answers read aloud. And to the right, there's a screenshot of the Catamage. So that way you all can see what it's like to interact with this tool. You can have the question here, and then you have different answers, and then the next button to move to the next question. But I want to show you to the top right is the audio button. And so when you click the Catamage, it automatically, when you click and you open up the Catamage and you begin the screening, it automatically begins to read aloud to you the question and the answers. And you can turn it off, but this essentially provided more accessibility and options for clients interacting with the screening tool. The screening tool has also been previously piloted, as Matt said, in various systems and with various populations. So when we were embarking on this implementation work that had 2 simultaneous projects across multiple systems and in various settings, we went to the implementation literature to see what implementation frameworks could help us organize and conceptualize this work. And reading through different frameworks, we selected the Interactive Systems Framework for Dissemination and Implementation to really understand how an evidence-driven tool like the Catamage can be adapted across systems to solve a specific or address a specific problem. And so this chart is an illustration of the framework. In this outer circle, the implementation work is contextualized with funding structures, policy, existing theory and research, and then the social and political climate. And then within this circle are the 3 stages for implementation. The first is building capacity for implementation, creating partnerships. The second is sustaining implementation tasks and problem solving as institutional conditions shift. And for us, working across multiple systems and settings, even without the COVID-19 pandemic, this was going to be the case, which is why this framework was very useful for us. And then the third box at the bottom is distilling information, essentially translating what about this evidence-based or evidence-driven tool is useful for this problem and in this system context. And I want to draw everyone's attention to the arrows on the right that are bright red that sort of move in between these boxes. And so while this framework has distinct elements, they're not rigid boundaries. And so as you're moving through real world implementation to solve real world problems, you can move back and forth, back to problem solving, and then back to reiterative support, which is really useful for our project.
So we'll start, and as the figure illustrates, this is definitely not a clean and discrete process. It's not like, oh, today we've finished the synthesis and translation, and now we're moving into the next system. So we're going to kind of use these different systems, somewhat loosely to talk about some of the key processes that were happening within each of these systems. So first, in terms of synthesis and translation, we really started with key questions like, could the Catamage be useful in a probation system? If so, how? What could be the potential utility of it? Of course, as I said, many of these questions came about from the Justice Mental Health collaborative meetings. And then really, once we decided on moving forward with this tool, the questions were how to translate the Catamage to the probation setting. The Catamage was chosen through the JMHC's review of screening instruments. And I think a couple features of the Catamage that were particularly attractive to the Justice and Mental Health Collaborative, and then to me and to Cook County Health and the Adult Probation Department. First was its ability to screen across many mental health and substance use domains. And so there's various domains like anxiety, PTSD, substance use disorders, that we could essentially choose what domains would go into it. So unlike a static instrument, as Sam mentioned, that basically is like a paper and pencil assessment where you have 52 questions and you have to answer them all. There was some flexibility, but also a range of issues that could be screened. The second piece was that this operated from a web-based platform. It's an interactive tool that as each question is answered, the server-based algorithm chooses the next item. And so for each domain, there are additional questions given based on the previous answer to most efficiently come up with a set of questions that could assess, a certain level of sensitivity to the issue. So instead of having to ask 30 questions about depression, if someone's answers are fairly consistent towards moderate depression, then the tool would adaptively select more discriminatory items until it crosses a threshold to say, okay, we're pretty confident about how we're assessing depression. Now we can move on. So the web-based platform provided some efficiency for folks who would fill out the Catamage, but it also really, so it optimized the screening, but because the data is collected electronically on a web-based server, it really optimized data collection and management because the data are collected in real time. If any of you have worked with sort of real world projects where you're having to translate any kind of clinical process to a data management system, it can be very time consuming and burdensome. But in many ways, the data are automatically sort of collected and managed in a way that's very usable. Speaking to the care coordination side with Cook County Health, it also offered real-time opportunity to make service referrals. So we won't go too deep into this, but essentially, as soon as the Catamage is completed, the results of each domain are calculated within seconds, and we in collaboration with Cook County Health and the Probation Department could decide on what constitutes a referral. And so we could, be flexible in deciding like what kinds of issues could trigger a referral. And in real time, an email referral could be sent to a provider that could then do follow-up with the client. So these were some of the things that made it appealing. And through the bond court pilot, it was instructive to this process because we were starting to see how this tool might be used with the criminal legal involved population, which it had not been done before. So the paper that's, just the abstract is highlighted on the right, was a paper that came out last year focusing on the findings from this bond court pilot. Basically showing that this tool could be used with a criminal legal involved population, and the validation process proved effective for folks going through the bond court with some adjustments. So this process of validation led to the removal of 9 items. So taking out 9 items out of a bank of about 1,500 items in terms of those items not being particularly suited well to the population. And so that validation through the bond court pilot really helped to inform how we used it in the probation setting. So continuing in talking about the synthesis and translation system, the interrelated projects began with some pretty intensive collaborative planning. So lots of just sitting down in rooms together with various folks from APD, as Adult Probation Department, Cook County Health, CCH, and the research team. And so we had to think through many issues around intersystem engagement. What was the primary purpose of each system? How to focus on probation client needs and how these systems could work together, particularly in ways, as Sam mentioned earlier on, in ways that don't further expand the reach of the criminal legal system, ways that don't criminalize issues around behavioral health needs, and ways that really that focus on the client experience. So one of the key issues we had to work through was information flow. Who needed to know what and for what purpose? So we worked to create a firewall between what clients reported on the Catamage, ensuring that this information would not be shared with the specific to any particular individual with the probation department. So it was important that clients that were doing this screening could know that if they marked any issues around mental health or substance use, that information would not go back to their probation officer, that it was only used, it would only be sent to Cook County Health for voluntary care coordination, and they could choose not to continue in that. And as a research partner, we work with the aggregate data in conjunction with the Adult Probation Department and Cook County Health. So we do share data and talk about data, but it's at the aggregate level. We also did a lot of work in this stage on practitioner-friendly products. So we worked to capture as much of the process, even as it was evolving, and workflows. We try to capture as much of this as we could. So there's an example on the right of how the Catamage would be administered. how, and Sam's going to talk more specifically about the in-person administration, but we would create like a simple flow chart like this, just so as a team, we could talk through each stage of the process. And then we used a flow chart like this to develop training materials. The training was targeted mostly for probation officers and supervisors. And Sam will get into some of these issues of training as she talks about the implementation rollout.
Thank you. So Matt was speaking about building capacity, establishing protocol and partnerships. I'm going to be speaking about the second part of implementation, which is really about rolling out these steps and then continuing to support them in organizational and institutional shifts. So we kind of have two parts to this. One is beginning in fall 2019 with in-person implementation. But as everybody here knows, in spring 2020, we had to shift to remote implementation. And so first, I'm going to talk about in-person implementation, what that looked like, what worked and what was challenging before moving to remote implementation. So we began in person. This is actually an image of the adult probation department at 26 in California in Chicago. If anyone's been to this department before, it's in the basement of a building, and probation officers sit in these cubicles, and that's where they complete their intakes and meetings with clients. And so what we did was we integrated the Catamage screening tool into that intake. So after the probation officer would complete the intake with the client, they would hand the client a Amazon tablet. One of the useful things about the Catamage as a tool is that it can be accessible through various different sort of technology formats. So we didn't have to have a desktop to use. We could use these tablets. However, probation departments don't consistently have internet. And then also for this particular site, because it was in the basement of the building, internet was really spotty. And so we connected the tablets to hotspots. So we had this entire setup where a client checks in at the front desk for the probation department. The probation officer brings the client to their cubicle, completes the intake, then hands the client the tablet. The client completes the Catamage screening in the probation officer's cubicle. And then at which point the officer connects them with a social worker from Cook County Health on site. And so that connection was instant. And so in order to maintain sort of this process, we had to have ongoing booster sessions with probation officers and social workers, particularly showing probation officers how to pull up the Catamage, how to log in, and then also to have the Catamage preloaded onto the tablet for clients who are being handed the tablet. So a couple of things about this worked. We were able to connect clients voluntarily to services, and that connection was immediate. So the probation officer could walk the client to an on-site social worker from Cook County and immediately have that connection. And we were also able to make that trade-off from identification to services without revealing any private information about the client to the probation officer. And so the way we did that was we created a little box. On the image to the right is the last screen that gets pulled up when a client completes the Catamage screening. And so that little black box with stripes was an indicator to the probation officer that they should be connected to a social worker. And the probation officer didn't receive any results and didn't know necessarily the inclusion or exclusion criteria for that connection. They just knew that they needed to walk the client to the social worker and make that introduction. And so that was an immediate connection that was able to be made while protecting clients' right to privacy. And we were able to implement this in 3 different departments. And each department sort of had it, as Matt talked about, its own flow chart and its own specific organizational sort of norms and contexts. But as you can imagine, there were things about this that were challenging. And these were often specific to sort of the rigid and punitive norms of probation departments that people cannot be left unsupervised. And so a client has to be escorted to the social worker, and then the social worker from Cook County Health has to walk the person out of the building. So there's some of these very specific norms that may not be the case in social service settings were the case in the probation departments. Clients also completed the Catamage screening tool in the cubicle in front of the officer. And so while the officer handing the client the tablet was not mandated, it was encouraged, it can still be uncomfortable to sit in front of the probation officer and complete a screening, even though the screen was private and the results were private. And then there was difficulty finding consistent spaces for social workers to meet with clients. And then just generally the work of sustaining all of these processes as probation departments continue to sort of shift. There can be a lot of turnover in probation departments as internet comes in and out. It can be slow and cumbersome and difficult to maintain. And so I actually have pulled memos from this specific period in time for you all to see. One memo that we took down in November 2019, we heard this from both probation officers and social workers, was that clients felt the questions were too similar and repetitive and it was taking too long. Again, this is in the context of clients completing this in the probation officer's cubicle. Trouble adapting to the hard boundaries of the probation department, the very specific rules that needed to be followed in order to identify clients in person and then connecting to services. And then this sort of longer memo is really discussing like the difficulty of sustaining internet connection and the particulars of which browser the Catamage works best on. And so while the Catamage is this evidence-driven tool, it has to be usable in person, which requires thinking about which internet browser is the most reliable for clients as they're taking it. And then shifting to implementation during the pandemic, moving remotely. What we did during this period, when it was no longer possible to do this work in person, probation officers were not meeting with clients in person, is that we received phone numbers from adult probation and we sent a text message directly to clients' phones. And on the right, I have a picture of a smartphone and then the exact script that we use to introduce the Catamage to clients. So that way you all can get a sense of how a client might experience this. We had an introduction in that text message to the Catamage in both English and Spanish. Each text message had a unique link to the Catamage, so that way every client had their own Catamage screening. We had reminders to complete the Catamage sent out in both English and in Spanish. And then we had a stop mechanism, and this is partly legally required. So clients can text stop and no longer be receiving updates and reminders to complete the Catamage. Although this rarely happens, it is an option. Something else that's shifted during this period is that referrals to social workers became remote, so they were no longer being connected instantly in person. And then the role of probation officers shifted. No longer was the Catamage being completed in the probation department in the cubicle. Clients could complete the Catamage on their own time in different settings. And really the role of the probation officer at this point is to let the client know that they should be expecting this text message, and that while it's not mandated, it is encouraged. And the probation officer underlining for clients that they will not know the results of the screening.
So obviously, for sake of time to do this in a concise presentation, we sort of moved through these various stages, in a matter of minutes. But I also had to sort of even, smile to myself as Sam was talking about these challenges because, with the in-person administration, I don't consider myself an expert on Wi-Fi connectivity and how to even use a hotspot. So we really had to do lots of consulting with different folks, taking the actual, instruments and devices to various settings and finding out, oh, it works really good here, but if you go around the corner, it doesn't. So these are, as Harold alluded to, these are the things that don't often make it to the pages of a academic paper, but very much affect whether implementation can be successful. And I don't think we can understate how impactful the pandemic was, because not only was the probation department, essentially shut down in-person, functions. So officers were working from home, clients were, meeting with their officers remotely. Everything changed during this time. So there was a period of quite a few months where we had to really ask ourselves, like, can this project continue? We also realized that the probation department and Cook County Health were responding to a variety of issues and questions and concerns related to the pandemic. And so, Sam and I and the research team really had to think about how can this project move forward in a way that doesn't compete with these very, critical priorities that each system has. And so moving towards this remote administration where, and I also want to, call out, really collaborative planning from Adaptive Testing Technologies, which is the company that supports the Catamage. We really had, we went back to them a couple times and just said, we're stuck here. Like we did all this stuff with Kindles and figuring out how to, keep them charged and connected. And now none of that can happen. And so thinking through how to move towards remote administration really helped us to utilize the functionality of the Catamage. The Catamage from its start doesn't require an in-person administration. You don't have to be sitting with the client for them to do the Catamage. So that provided us real opportunities to do some creative problem solving. So that has been really a piece that has been very functional and working very well. Like at the systems level, we've worked with Adaptive Testing Technology that to send out you could send out thousands of texts at a time. Instead of having, you picture with the in-person administration, each time a Catamage was completed, that meant a probation officer was sitting down with a client, handing them a Kindle each time, logging them in. So to do 100 of those, it would take 100 of those processes versus setting up a system that could send out thousands of texts with individualized Catamage links that essentially takes the probation officer, as Sam said, sort of out of the equation. So we don't have to do intensive training with officers. It really doesn't, this remote administration essentially didn't add any time to their work. It also allows clients to be able to complete the Catamage when they want to, and not, as Sam said, not sitting across from their probation officer. So if they want to do it, on their own time at night, whenever they choose to do it, they could do it. Part of what we've also seen as being really effective with the Catamage implementation is the ability to change referral criteria. So initially, and everything that Sam talked about in terms of both of these processes, we initially did them in very focused pilot ways. Like we didn't train all officers, we trained a few units. And so initially we had fairly small numbers of Catamages being completed. So we had fairly sensitive referral criteria. So, any substance use or mental health, need would trigger a referral. Through the process, and as we started to expand the implementation, we had to look at issues of capacity from, Cook County Health and folks that they contract with. They've later contracted with Family Guidance Center, who's been really effective at responding to these service referrals. But we can talk in real time about what should trigger a referral. And then on our end, we can adapt the referral mechanism. Again, it doesn't mean that a person has to look at it and decide if it's a referral. We set the referral criteria and it's automatically done instantaneously after the person completes the Catamage. So these are all great things. This process is definitely not without its challenges. As we move to remote administration, it brought up all new questions around data sharing, how we could share data, what permissions were needed. One of the primary obstacles that we had to work through was this process of texting the Catamage link to clients required that we would have access to the phone numbers and first names of clients so that we could send the text. And also if there was a referral that needed to be made, that the person from Cook County Health or Family Guidance Center at least knew the first name of the person. So that required going back through the IRB and then, getting buy-in from the probation department to be able to share those names and numbers, which took some time. Even things like the probation system going through a different case management system and having to implement that, just in the last few months sort of delayed some of the data we could get. The second major issue that we've been facing with the remote implementation is essentially the uptake of the Catamage from the text. So is trying to make sure that clients aren't surprised when they get this text. I think if any of us received a cold text that said, click on this link, to do this thing, I would hope that most of us would not click on the link because, of all the concerns about what's actually happening. So we had to really start thinking about how can we ensure that clients will actually know why they're receiving the text, that it's safe, and that their information won't be shared with the probation officer.
We want to share some of the results from the in-person implementation and the remote implementation. And so on the left, we have the implementation results for in-person. In-person, we trained 22 probation officers across 7 units, and that's in 3 sites. A little over 150 Catamage screenings were created, and 96 of them were completed. And on average, with the client sitting in the probation officer's cubicle with the tablet, the average time spending on the Catamage was 11 and a half minutes. Moving to the right with remote implementation, we've sent over, as of April 2020, we've sent out over 16,000 text messages. We've sent out over 32,000 reminders to complete the Catamage. And we have also different reminders for if a client hasn't clicked the link to start the test or the screening. And then we have another reminder for clients who have begun the Catamage screening but haven't finished it. So we have a more personalized reminder. In that context, we have 768 Catamages completed. And then with clients completing the Catamage on their own time in various settings, the average time spent on the Catamage is 9.5 minutes.
So I'm going to shift a little bit now and just show some of the preliminary data from these 768 Catamages that were completed. This is very preliminary. We're still very much in the process of analyzing these initial data, as we're also consistently getting new data in as more Catamages are completed. But what this table shows are the various domains of the Catamage, and it also shows the severity or risk level within each domain. And those risk levels were determined by the creators of the Catamage based on synthesizing clinical cutoff scores from a range of screening instruments. So a couple of findings that I just would touch on. First, that this is not surprising, but there are fairly high rates of mental health issues among the folks who completed the Catamage, particularly depression, where 26% of folks screened positive for having the potential of major depressive disorder, and over 1/4 of the folks that completed the Catamage screening moderate or severe for psychosis. On the other hand, SUD, which is over on the left, which is substance use disorder, just over 11% screened at an intermediate or high risk, which is not as high as we would have expected, given that so many people that enter the criminal legal system, from past research, we see that so many folks going into the system have substance use needs. On the other hand, this is not necessarily surprising because clients may be likely to underreport substance use for fear of legal implications. I mean, many moons ago, I was a practicing social worker and I worked in a jail in the intake area doing behavioral health screening to try to help connect folks to services. And I asked these questions, face to face, that the Catamage, similar questions to the Catamage. And, when you're in a criminal legal setting, when the questions originate from a criminal legal source, there's always questions about how somebody might be, harmed or criminalized for answering those questions. So this is an issue that we're, continuing to look at. So I'm just going to take a few minutes as we wrap up to talk about some of the challenges and opportunities and how we're planning to move forward, and then really look forward to your questions and discussion. So as I just mentioned, we have had a low uptake on the initial text-based approach. It was about a little under 5%. And through this process, we've really identified multiple ways or multiple things that might be impacting it. We think that one of the biggest issues is just that clients may not fully understand why they're receiving the text. They get it and are not sure what to do with it. And so they err on the side of caution and don't click on the link. And so in late 2021, we developed some very brief trainings. Again, we did this in conjunction with the probation department. We first met with the deputy chiefs and talked about what would be feasible to make sure that a client, before a client received the text, that they had some interaction with somebody from the probation department that would sort of cue them up to know about the Catamage. So we developed some trainings. Again, it was still during COVID, so we did these basically through a recorded presentation. We did this through Zoom with supervisors from the probation department. So we were able to meet with all supervisors to inform them about the Catamage, to show them a little bit about the process, and then to say why it was critical that court liaisons and probation officers, who are the two individuals that actually have conversations with probation clients as they enter probation, why it would be critical for them to spend a bit of time, to let them know that this text would be coming and that they wouldn't be receiving the results. And so again, this is sort of a critical piece. Like we worked this out, and we actually modeled it in the training, so that we said that both court liaisons and probation officers could communicate these issues to a client in about 30 seconds. And we've also done a video booster, that could be sent out. So again, taking advantage of remote technology, and that it would be really difficult to train the hundreds of officers, in person. We've already seen some promising results. So in the last batch of texts that we sent out, the response rate was around 14%, which is almost 3 times the initial response rate. And there's still been some lag, because of the way we receive the data. So some folks might have heard about it from their officer, but had to wait a couple months before they got the text. And we're moving towards doing this on a monthly basis. We still are exploring these issues of institutional trust to make sure that in any way possible, we're communicating with probation clients that this information will not be shared and can't be used by the criminal legal system, to punish them. As we start to this is part of the ongoing implementation, as we develop some of these enhancements and adaptations, we'll be looking at whether self-reported substance use issues go up. And we'll also potentially be triangulating these data with other probation data, such as positive drug tests. Coming back to the interactive systems framework, part of the challenge and opportunity moving forward is to maintain these functioning organizations. So when you're working with several agencies like probation and Cook County Health, you have staffing and leadership, turnover and shifting of priorities. So consistently, meeting to calibrate. We still meet every other week with these interagency leaders to talk about the project, how to move forward. The other big questions really come around continuing this Catamage over time. So we're finally at a point, knock on wood, where we're consistently going to be able to send out a batch of text monthly. So we can pretty much ensure that the time between a client entering probation and hearing about the Catamage, they also get a flyer either in person or electronically, that no more than a month passes before they actually receive the Catamage. And once we start to receive that monthly data, we'll be able to see in real time how the different enhancements and implementation are affecting both Catamage uptake and what's being reported on the Catamage. Ultimately, over the next year, we're going to be working with the probation department to decide whether this is something that they want to move towards regular practice. And if so, how to move the Catamage towards regular practice in a way that doesn't, that is not coercive and not in a way that continues any punishment or enhances any punishment for people involved in the criminal legal system. And then lastly, just a brief note on how we move forward. You know, we're continuing, you know, the interaction of these systems. You know, we're both in the delivery system, but also continually synthesizing new information. We're updating training materials. You know, keeping track of these and documenting these is essential, you know, so that if other departments want to implement something like this, that they don't have to, you know, reinvent the wheel. And our role as a research partner has really been both challenging, but also, you know, an interesting opportunity to sort of serve as a connection between these systems and think through issues with them, whether it's, you know, how to interpret the results or how to collect data, or how to train folks. So it's been a really interesting opportunity to sort of be a liaison between these agencies. And then the fruit of the implementation on the clinical side really looks at how the Catamage screening can trigger a treatment referral and hopefully care coordination that happens outside of the probation system, and hopefully, you know, engagement and services that will continue beyond somebody's time on supervision and probation. As we continue to move forward with this, there's an opportunity to use the Catamage data in an aggregate way to help the probation system develop more responsive programming and practices. So in other words, if we see that there's high levels of certain types of mental health concerns that are coming up, maybe it's a matter of working with the probation department to seek out specific trainings in those areas or ways that probation could be more responsive. And then, as I said earlier, we will be integrating the Catamage data with probation data and other data, which really will provide, I believe, one of the largest data sets on issues of behavioral health, probation outcomes, and then later criminal legal outcomes. So we can really speak specifically to how those issues impact future criminal legal involvement. And so I just want to acknowledge that the grant to the University of Chicago is supported by the Laura and John Arnold Foundation, that there has been intensive collaborative work between us, our research team at the University of Chicago, and the Cook County Adult Probation Department, Cook County Health, and then more recently Family Guidance Center. And I neglected to put in a bullet point on here, the ongoing collaboration with adaptive testing technologies. So sorry about the ATT folks. It was certainly was not intentional. You've been a huge part of whatever successes that we've achieved so far in this project. And so we really just want to thank you again. We're from the Smart Decarceration Project. This is our website. We'd love for you to check it out and see some of the other work that we're doing. And we're happy to open it up for some Q&A time.
Great. Why don't I start with some questions that showed up in the chat? One question from Jesus Hernandez was, how has telehealth changed how you deliver services? And I think to some extent, if you want to elaborate, you made some comments, but if you want to elaborate on that.
Yeah, well, I think you know, we're all much more used to doing the work that we do without being in person. And in telehealth, I think in terms of acceptability and normalization of telehealth has definitely, I think, facilitated you know, service referrals in this project. So as Sam mentioned, when we moved to the remote administration, you know, the follow-up was then done by phone. And, you know, right now it's folks from Family Guidance Center who are reaching out to an individual, you know, and as an agency, they've had to work over the last 2 years about how to do their work with clients when they can't do it in person. And so they've anytime you have to contact somebody by phone, it's a challenge, right? Because phone numbers change. People may not answer, so you might be playing some phone tag back and forth. But I think increasingly, behavioral health services are at least initially accessed in ways that are remote, and in many ways, part of the service delivery is remote, or has increasingly remote, which is helpful. Add on that,
Sam, do you have anything to add on that?
Yeah, I'll just say that even before the pandemic, I think social workers made cold calls, right? Because you get a referral and you have to call a client and introduce yourself and introduce the services. And I think that the screening, the identification, the connection going remote had some things about it that were innovative and useful, and some things about it that were actually pretty normal for social workers who were doing things. I think, as Matt said, making the services more accessible remotely has been helpful for clients that may not be able to travel far distances, having different options, right? Just expanding the menu of service options for them.
One thing, some of the physical locations for services that people need in behavioral health are kind of depressing and sometimes difficult to get to. And I can imagine some people probably would prefer to have a remote modality, I can just sit I can be talking like I'm talking to you on Zoom right now, and you can send us prescription to my pharmacy for buprenorphine or whatever. I can see that could be a real advantage. Question from Jean Marsh. Can you tell us more about the handoff to the social worker, and what if a need was identified that the social worker did not have the resources or capacity to meet?
Yeah, so this is some of the ongoing work that we're doing. I think part of why Cook County Health has been an important partner is that they have potential access to a range of health services. So even if the social worker may not immediately be able to address whatever need comes up, because say it's a substance use issue from the Catamage that triggers the referral, but then when there's a follow-up, there might be other health needs that are, or other, broader needs that are identified. It's also part of why I think it was important that Family Guidance Center was brought in as a contract provider to do these services, because they're part of a network, a consortium of behavioral health providers. So they're really doing, their function is really to do, further assessment into the issues and then to do connections. So, and I also see that this is kind of related. I think I see in one of the questions was, what were the most common social services individuals are referred to? We don't have an answer on that yet. This is data that we're just starting to get from the service providers. So we're going to be looking at those, but anecdotally, we've heard about everything from housing kinds of services to obviously behavioral health, because the Cook County Health Project focuses on opiate use disorders. They're looking at evidence informed treatments, medication assisted treatments that they can connect folks to. We've also heard anecdotally, about people saying like, oh, I have a family member or a friend that might need some services. And so in some ways, this connection, through the person's involvement in probation could lead to other folks being connected, not through the criminal legal system, but through systems supported by health agencies to connect folks to services.
A couple other questions in the chat. One is, trust is key in this process. This is from Fred Nelson. Trust is key in this whole process. How do you communicate who you are to the probationers? Do you brand yourself in any particular ways?
Brand ourselves. Sam, what do you think about this one?
Yeah, I'm thinking about it. I mean, as Matt said in the presentation, we're thinking about institutional trust or the lack thereof when it comes to the data. One thing I think that's important right now is that clients receive a text message and it looks like the text message is coming from adult probation as like the contact on their phone, even though it's being distributed through ATT. And so Matt and I are not interacting with clients sentenced to probation. I think right now what we're focusing on is making sure that people know that this isn't spam, this is voluntary, and what it can do for them, right? Like this can get you connected to services that are voluntary, and whatever you identify as a need through the screening will not be reported to your probation officer or to the department. It's not going to impact your legal status. So I think being as transparent about that it's not going to impact their legal status, and that completing it can actually do something for them materially in terms of getting them connected to services outside the criminal legal system that are voluntary.
One thing I was wondering about is whether there are other trusted people that you might bring in to sort of vouch for this, like public defenders or other people that are in the environment who could potentially help recruit people or reassure people. Are there others in the system who could vouch for this in a useful way?
There definitely could be others, and I would say the initial justice and mental health, or I see a comment also like peers. These are all great ideas. This is the challenge. These ideas might be helpful in terms of the initial introduction to the person, like you're going to get a text. The challenge is once we actually send the text, this has been like the dilemma, how to provide as much information as possible, but also, as any of us knows, when you receive a text that's several paragraphs long, it can start to, you get lost in the information. And so how to be concise, but as informative as possible has been a real challenge with the text-based communication system. So, we've focused on letting them know why they're receiving the text, as quickly as possible, what the Catamage is and what it'll be screening, and that there might be a follow-up, connection from Cook County Health that is completely voluntary. It's not something that they have to do. And on the referral side, when the Family Guidance Center reaches out, they've been great about, ensuring like this started from the Catamage, but now this is separate from probation. But thinking about peers or defenders are great ideas, because we will be continuing to think about how to make sure clients can be trusting of this process. It's one of those dilemmas. I will say myself, working with folks involved in the criminal legal system, and it's I think IRB processes rightly ensure that there's not coercion, that people understand that it's voluntary, but sometimes you can focus so much on the fact that it's voluntary and call so much attention to that it's not being shared in the criminal legal system that it might actually raise questions like, they've said this 3 or 4 times, like maybe I should be more worried about this. So, we might even be looking at, if this works, continues to move forward beyond the current project, we might be looking at doing, some focus groups or interviews with clients to understand, some of their concerns or pieces that could be more helpful in helping them to complete the screening.
A couple more questions in the chat. One is are these data protected under HIPAA? And how does HIPAA enter this thing?
Some of the specific, if there are specific diagnoses or anything, that's not so much the result of the Catamage. The follow-up from the folks who do the follow-up from the Catamage and may connect to services, that's part of their ongoing, service delivery that's protected by HIPAA, as part of their clinical services.
Then here's a comment from Leah Jacobs. Thanks, Samantha and Matt, for sharing this tremendous amount of work. I'm wondering how the warm handoff can really blind POs. Are there non-diagnostic reasons the referral would be triggered? Also, are you blinding probation involvement on the provider side? And a separate question, you referred to using a community engagement approach and spoke to some of the influences of provider feedback in the process. Can you speak to how service user input influenced the process?
Sure, thanks, Leah. So the first question, So to be clear, the warm handoff with the PO was part of the initial in-person implementation. That's not happening anymore. But you're right that that a probation officer seeing a visual cue that they should bring them over to the social worker, you know, might suggest that there's some issue, but it could be the way we, you know, trained officers. They know that the Catamage covers a whole range of issues, of everything from mental health issues to substance use, and so while, but they didn't know because this criteria evolve, you know, what triggers a referral. And so, you know, essentially, we also know that mental health issues can be criminalized in the criminal legal system. But I think the most immediate concerns is that we didn't want officers to have any information specific to substance use. I do think this has been an enhancement of the remote administration. Is that, you know, officers don't know whether their client completes the Catamage. They don't know if there was now with your remote administration, they don't know if there was a referral as a result of that. And they also don't know whether the individual is doing any ongoing services. And this kind of gets at your second question. Are we blinding probation involvement on the provider side? Now, the initial provider that reaches out, Family Guidance Center, they know where the referral comes from. So they know that the person is on probation. And it's part of how they engage with the person. They say, you know, we know you did this screening through probation. We're following up separately. In terms of if there's ongoing services and whether, you know, probation receives any data, that is completely up to the client. And we've really worked through with both the probation folks and the service folks to say, because there might be a case where a person on probation is mandated to, you know, to receive some kind of substance use services, let's say. And so if the client, you know, believes that getting some ongoing services might actually help their, you know, meet some of the requirements of probation, they can choose to sign a release to have that information shared back with the officer. But that decisional process is in the hands of the client. And Family Guidance Center, you know, has really focused on, you know, helping previous to that, the Cook County Health social workers were really navigating that with the client to help them think through it. Like, you don't have to share this with the officer and what might be helpful, and not just do you share it, but what information would you like shared? Maybe it's just that you're going to these outpatient appointments and not necessarily, you know, the in-depth, you know, content of those. Sam, do you have other thoughts on this?
I'll say that in terms of buy-in from adult probation and specifically probation officers, the movement to remote, I mean, this process asks very little of them, and clients can access services. And actually, in some of the remote trainings, we've been able to introduce family guidance providers to probation officers, and they've made direct referrals even outside the Catamage. And so finding various ways to connect people with services and making sure that clients have agency and determination over their own process.
Two more questions come to mind as I was listening to your responses. One is on this question of whether it kind of cues the PO in that there's a potential behavioral health issue. Have you thought about maybe including some social determinants in the screening, like housing services, things like that, where, first of all, people need those obviously, but secondly, that would somewhat blind the PO if there was a referral, a cue for a social work referral, that it could be a social determinant issue and not a behavioral health issue.
I like that idea. I think one of goes to the back and forth between what are the challenges and the opportunities of having a computer adaptive tool like this. Mm-hmm. Is that it can be fairly challenging to add you know, questions, or especially whole domains, mm-hmm. because you know, it's a lot of programming on the adaptive testing side. So we have, but I will say, part of the, the officers, they generally know that it's about social services in general. And even back in the in-person administration, when we did the training with them, we would log in a device on the Catamage and they could sort of flip through and hit some questions, but they don't really have a full understanding of all of the questions, that are asked or all of the topics that are asked. I don't think we, had we continued in the in-person administration, but these are also really great questions for, as we think about with the probation department, if they move towards this becoming a more regular practice. These are the kinds of questions that we're going to need to be engaged in, because if probation officers end up more informed about their clients completing the Catamage, and potentially if there's any service referrals from that, we would want to make sure that only happens, like, these are issues, these are issues that are client focused, and whether that information about these personal parts of a client's life become privy to the probation system should be controlled by the client. And that will be our priority moving forward, to make sure that this doesn't create like further expansion of surveillance.
That actually, it kind of anticipates in a negative way. And another question I was going to ask, which is, what if someone has an immediate threat to self or others, that, the suicidality, something like that. The Catamage does have some suicidality capabilities. How do you address issues of that nature in this?
Well, this is part of the, in the initial meetings, we went through the various domains, and we made the decision collaboratively with probation and with Cook County Health to not include the suicide risk questions in this implementation. So clients who complete the Catamage through probation do not complete, primarily because we were concerned about especially with remote administration or something. And this is common with Catamage implementation, like various implementations don't necessarily use all of the modules. And the concern was that these systems may not have the capacity to respond in real time, especially to a high risk. So I don't think there's anything in the Catamage about harm to others. But for those reasons, in the real world implementation, the suicidality module is not included.
Just saying, the reducing opioid mortality in Illinois trial, we made some of the same decisions, but in our initial screen, that because we couldn't really address that problem. I think a lot of people have faced this dilemma. It's just a really, really tough one, because obviously you want to help people, but it's not clear that.
Yeah, and I think on the clinical side, my own training as a social worker would say, any question you ask, you should be able to justify why you're asking it and what you are going to do with the information. So whether that information might be helpful, like on a research side, is run by whether there can be a appropriate clinical response, which in this case the providers were not able to do it.
But when I will just parenthetically say, I wish that the people in the IRB had clinical expertise, because this is the kind of thing you end up with in a dialogue with the IRB about. And often you're in dialogue with people who are social scientists, not clinicians, and sometimes the conversation is not sensitive to the nuance of the clinical setting in that way. Because but we've reached, I don't know that we've reached thematic saturation, but we've reached temporal saturation. So thank you guys. This was just a really great presentation. Thank you everyone for putting in the great questions. And I just feel really enriched by the conversation, and thanks everyone for coming. And any last minute closing comments that you guys would like to make?
Sam?
No, just thank you for having us.
Yeah, thanks so much. Really appreciate the opportunity.
Everyone have a great day. Stay safe.
Bye.
Bye.